This is Tavish Donahue, Project Manager with HealthierHere, and you are on our May Partner Summit webinar. Now, we've got about 60 people on the line today, so thank you so much for taking time out of your busy day to join us. As a heads up, we will probably not need the whole 90 minutes. This webinar will be about 50 minutes to an hour, so hopefully the technical difficulties and that delay won't derail us too much. Some other technical issues. Right now we have everyone muted to avoid feedback. So if you have any questions or comments, please just type those into the questions pane at any time, and our staff will help get you a quick answer. And if there's questions or comments that are applicable to the larger group, we're going to repeat those to everyone's benefit. Okay, so we have two main goals for today. The first is to share some key updates from HealthierHere's recent work. And then we are going to dive a little bit deeper into the results of our current state assessment. This current state assessment, which is a kind of very expansive survey, it was sent to our health and behavioral health partners over the last few months. So if you are on the line and you're a CBO or a non-Medicaid billing provider and you did not receive this, don't worry. We are going to have a separate survey for our community and social services partners coming out this summer. So please stay tuned for that. Okay, here is our agenda for today. As I mentioned, we're going to share some HealthierHere updates, mostly about hiring, and then some of our upcoming state deliverables. Then we're going to talk a little bit about our pivot to implementation planning. Then we're going to do some finance updates. And then agenda item number 5, which is going to take the bulk of our time today, the results of HealthierHere's current state assessment. Okay, so now for our HealthierHere updates. Our team continues to grow, and we have an exciting new hire to announce. Michael McKee, who is our Director of Clinical Practice Transformation. We have Michael in the room today, so I'm going to ask him to say a few words.
Hi, everyone. Thanks so much. I'm looking at the participants, and I recognize that I do know some of you from my past work, and some of you I look forward to meeting in my new role at HealthierHere. Just if you'll indulge me a little bit, I thought some folks who may not know me would be interested in knowing a little bit about my background. I've most recently come from working with the Federally Qualified Health Center, International Community Health Services, and I was there a little over 12 and a half years and had an opportunity to work on a number of projects to innovate healthcare delivery, sometimes utilizing community health workers, looking at how health information technology could be leveraged to operationalize CDC guidelines, as well as to innovate with some community partners like Asian Counseling and Referral Service on primary behavioral health care integration. And I'm just super excited to join HealthierHere and to take what I've learned over the last 12 years and apply it on a systems level and work with all of you as partners and stakeholders in this Medicaid reform project. So look forward to meeting some of you and working with others in a new role. Thanks.
Okay, fantastic. Thank you so much, Michael. We are so excited to have you on board. And over the next few months, we'll be announcing some additional hires. We're going to be staffing up with some additional project managers and also some financial positions. So please stay tuned for that. Our second big update is that HealthierHere's website, our brand new HealthierHere.org, is going to be launching soon. We have been phasing out using the King County Medicaid transformation site, and we will have our own HealthierHere.org domain. So that website is going to be launching soon, likely sometime next week. And when that is ready to go, we're going to be sending out a newsletter announcing the new website. So please keep your eye on your email for that exciting announcement. Our next big update, upcoming state deliverables. So we have a semi-annual report due to the Healthcare Authority on July 31st. And the semi-annual report is going to be a standard deliverable from HealthierHere and the other 8 ACHs to the Healthcare Authority, due every 6 months. So that'll be on a standard cycle. Our other big deliverable coming up in 2018 is our implementation plan. And the implementation plan is a one-time deliverable. We need to provide the details of how we're going to implement our transformational project portfolio, which includes the 4 project areas: bi-directional integration of physical and behavioral health, care transitions, addressing the opioid crisis, chronic disease prevention, and we're also going to address our cross-cutting strategies around HIE, HIT investments, care coordination, and workforce. So those are our big Healthier Here updates. Now we are pivoting to implementation planning. So I had mentioned the big implementation plan that's due to the Healthcare Authority. We really need to get to a finer level of detail about what Healthier Here and all of our partners will really need to do, kind of the nuts and bolts of what system transformation is going to look like. We're going to be rolling out evidence-based approaches and best practices that we've committed to. So we really need to get from there to here and figure out the detail of what that is going to look like. And don't forget, Medicaid transformation is going to be a lot of work, but it's also a very big opportunity. This is our chance to test protocols and approaches that are not currently reimbursable through Medicaid, and we have the opportunity to transform organizations and practices to be successful in providing whole person care in a value-based payment environment. And in that value-based payment environment, we need to really fine-tune our data and technology, relationships with other sectors, especially social services and community-based organizations that are addressing the social determinants of health. We want to increase adoption of evidence-based practices and also really make the move to value-based payment and meet the metrics for the Healthcare Authority. So in our early stages of implementation planning, we've identified some of the key capacities that partnering providers will need in order to implement. So you can see here on this slide, we have several capacities at the patient care level and several capacities at the system level. So at the patient care level, we really need electronic health records, registries that link to EHRs, holistic screening processes, and multidisciplinary teams, including care coordinators and community health workers. At the systems level, we really want to expand evidence-based approaches and quality improvements. We're interested in partners who have a focus on measurement and outcomes, and also some population health management knowledge and tools. So if your organization currently has all these necessary capacities or is in the process of launching them, then you do have the key capacities to participate in our work as an implementing partner. And we are thinking of these capacities as a scale, so you can be anywhere on the scale of readiness from early adoption to fully implemented and working well. And in our implementation planning process, we started to identify potential partners. And last week we had a work session for our implementation work groups. And this was primarily health and behavioral health partners. And we had a really productive 4-hour work session, and all of our participants really helped Healthier Here think through the elements that will be part of our implementation plan. And that includes clinical protocols, whether or not our interventions have the ability to move the prescribed metrics, and also workflows. And we're going to be holding another implementation work group session in July. So if you were there last week, please stay tuned for more details. And we may also have organizations on the line who are ready to engage with us at these levels, but have not plugged in yet. Don't worry, you're not too late. And the first step that you need to do is to complete our financial executor survey. So this survey has been simplified now that we have our current state assessment, and it only takes a few minutes to complete. So I'm going to ask our CFO, Twee, to talk a little bit more about the FE portal process, and then she's going to move on to our finance updates.
Thank you, Tavish. Hi, this is Twee again, and I just want to clarify, because I've been receiving a lot of questions on the financial executor registration process. The first step that you do, as Tavish indicated, is completing this survey, which takes, I think, 15 minutes at most. But then once you've done that, the next step is then it passes on to Healthier Here, and then I will work with the PCG, which is the financial executor selected for the state of Washington, and then they do what we call employee identification number match with your organization's name with the IRS. Once that match is a positive match, then you will receive an email invitation to complete the remaining steps of the registration. So by doing the survey alone only kicks off the process. It doesn't complete it. Once you get that email from the PCG or the financial executor, then you have a log-on ID that you go in with a passcode, and then complete the rest, like your banking information, and then at the end of the process, the registration process, the online is a click agreement of the master services agreement. So when you click I accept, that actually completes the process, and as soon as you do that, I can then log into our view on HealthierHere and actually see your organization's completion. At that point, you are basically ready to receive payment from us once we start to distribute dollars. So then the next up, I'm going to log into the financial updates. So just a couple of things I want to share with you guys. The first is that a reminder that back in April at the governing board, they approved what I call the payment triggers for our DY1 engagement dollars. So I'm just going to share again what those are, and the first payment trigger is called Partner Organization Change Plan. That's a submission that HealthierHere will ask you to do. The second is just acknowledging the partner participation. The third item is the completion of the current state assessment, the HIE survey, which most of you, I think 98% of you are completed on that. The fourth is Medicaid volume, looking at 2016 data, Medicaid data of how many Medicaid beneficiaries each organization has served is what we'll be gauging the Medicaid volume on. The fifth trigger is signing the project-specific agreement, which feeds into the master services agreement that I mentioned earlier in the Executor of the portal. And then also completing the registration, successfully completing the registration in the portal. The last is a commitment to engage with us, remain with us for implementation by signing what I'm referring to at the moment is the Addendum 2 in the agreement. And then as far as next step for those is that at the June 7th governing board, the Finance Committee is going to make a recommendation as to the allocation of those dollars for DY1, and upon approval by the board, then the anticipated first payments that HealthierHere will send out to our providers will be in July. The next item I want to give you an update on is hinging on the payment trigger, one of which is the completion of the current state assessment, the HIE and HIT. What I want to share, and I know some of you have already heard this, but the due date for that is May 25th. Those have to be in by the 25th so that providers can get payment once the governing board approves the methodology. The third item is just a reminder that the registration in the portal, the financial executor, must be completed at this point on June 1st, so that we can again, once we receive the approval from the governing board, then I have time to go through the process to issue payments in July. Those are my main updates for this month. So if you have any questions.
Yeah, if you have any questions, we're going to have some staff email addresses at the end of the webinar. So feel free to reach out to us, and we'll connect you with Twee for more detail on some of these financial updates and steps.
Thank you.
Thank you. Okay, so now we're going to take a little pause before we move on to the current state assessment. So if you have any questions about what we've covered so far, please go ahead and enter them into the questions pane at this time. So I'm going to give you about a minute or two for that, if there's any lingering questions. Okay, so we've got a question about the link between the current state assessment and the payment portal. Yeah, how long after the submission of the current state assessment should partners wait before they receive the link to the financial portal? Yeah, it sounds like we just need to clarify which survey.
Yeah, so I would say that the two are definitely separate. So as of today, if you have not gone in and completed that King County survey, it certainly is on our website, or one of us can send that to you. And I would initiate that process sooner than later. The current state assessment has been out for a little while, so like I said, about 98% of you have completed that. So I wouldn't worry too much about that, because those we know who's not have not. We know who we're waiting for. And then so if you have not completed, again, the King County survey, then please let us know, and we can send that to you as soon as possible.
Yes, and when we follow up on this webinar, we're going to send out the slides from today. We will include a link to the financial King County survey, so everyone will have that. Yeah. Okay, so we have another survey question. This is about the difference between the current state assessment and the HIE assessment. So those are two separate assessments, but they went out to the same pool of organizations, which are Medicaid, health, and behavioral health organizations. So when we launch our CBO assessment later this summer, that will be a standalone survey, and our CBO partners will not need to fill out the HIE, HIT assessment. Okay, we've got another question asking about the confirmation process of whether or not partners are properly registered.
So if you have, I guess my short answer to that would be, if you feel like or suspect that you have not completed the entire process, you're welcome to email me, and I can log into the Financial Executor portal and verify if you've indeed completed the entire process. That probably is the easiest way. Also, if you have not received any email from me, because if you haven't completed the entire process, I did send out emails specifically to providers around May 2nd. So if you didn't get an email from me at that point in time, likely you have. But overall, if you're not sure, feel free to contact me and I can verify that for you.
Okay, great. Thank you so much, Twee. And if you have any other questions, feel free to type those out and we will answer them periodically. So now I'm going to move on to the main focus of our webinar today, the results of HealthierHere's current state assessment. As we've mentioned, the HealthierHere current state assessment went out to health and behavioral health Medicaid billing providers over the last few months, and we've had a great response rate. We're just trying to get the last few assessments back in by May 25th. And the current state assessment, it's very lengthy, very detailed, but we hope it's a good exercise for your organization to really think through, what your current capacities are and where you might want to go. This assessment is really key to helping HealthierHere understand the level of readiness for systems transformation at our partner organizations, and also the current capacities and community assets, the work that's already happening that we can build upon for system transformation. King County's data staff really helped out and performed the analysis of the current state assessment. Deb Srebnick in DCHS was our primary evaluator. Unfortunately, Deb couldn't be with us today, so one of her colleagues is stepping in, Jay Marshall, who's an epidemiologist at Public Health. So Jay, we have you on the line, and I'm going to kick things over to you.
Excellent. Thank you so much, Tavish.
You're welcome.
All right. Can you all see my screen?
Yes, we can.
Right. Awesome.
Yeah, you may want to get out of slide viewer mode.
Gotcha. Okay.
Okay, there you go. You're set.
Okay, great. Okay, so today, hi, my name's Jay Marshall. As Tavish said, I'm an epidemiologist with Public Health Seattle and King County. Deb couldn't be here today, so I'm going to discuss the current state assessment, or the results of the current state assessment. So quick overview, we're going to discuss the respondents, what provider organizations were surveyed. We're also going to talk about the infrastructure for the waiver work. We're going to look at workforce. We basically want to look at employee engagement and also employee buy-in We're going to talk about the all-important value-based payment, and then lastly, we're going to cover project-specific information for the 4 projects: bi-directional care, transitional care, opioids, and chronic disease. So, our respondents, we have 11 hospitals, 5 FQHCs, and 16 BHAs. So, you guys will notice that when we look at the bar charts, at the very beginning, most of them will have these same numbers for the hospitals, the FQHCs, and the BHAs. As we progress through the slides, maybe the N will change based on which of the organizations answered or opted out some of the questions. It's also important to note that some of these organizations cross settings, and so CMAR, for example, self-identified as a FQHC, and Harborview self-identifies as a hospital system. Additionally, some of the Novels consortium members, or these consortium members, are community-based organizations contracted by Novels to provide behavioral health care or behavioral health services. These we have 2 of these that reported as BHOs. So first, it is excellent to see that project level interest is very high across all projects. If we look at the FQHCs, look at the orange bars, and actually let me use this as an opportunity to orient everyone to the nature of these slides. So we have the blue bars, and these are representative of the hospitals. We have the orange bars, these are representative of the FQHCs, and the gray bars, which are representative of the behavioral health organizations. As I mentioned, sometimes the N will change, but I think for the majority of these, you'll see it will be for a percentage of the 11 hospitals, 5 FQHCs, and 16 behavioral health organizations. Okay, so moving back to this slide, project level interest is very high. We see a lot of interest for bi-directional integration. We see FQHCs are interested in all 4 projects, and we have hospitals also interested in bi-directional and chronic disease. Behavioral health organizations, as we would guess, maybe not so much interest in chronic disease, but still fairly high interest across all projects. Okay, next we'll discuss infrastructure for waiver work. So here we see that the services vary by setting. If we look at primary care, behavioral health organizations, and the question for this, the question here was, what services does your organization possess? And as you would guess, behavioral health organizations are pretty limited in their scope in terms of what primary care services they make available. Mental health services are available across settings. Substance abuse treatment, a little limited for hospitals, but pretty high, a little over 90% for behavioral health organizations. We see that oral health care services are quite limited outside of FQHCs. And we also see some varied fluctuation in social services. For this slide, we're looking at quality improvement and performance measures. And we ask organizations if they have a QI process. And almost all organizations have a quality improvement process. But it changes a bit when we move down the line. If you look at the next set of bars, are these strategies used continuously? About 80% of hospitals and FQHCs answered yes. But for the behavioral health organizations, it was only about half. And then when we ask, are comprehensive performance measures fed back to providers? We see that all the FQHCs said yes, and maybe about 80% of the hospitals said yes. Less than 20% of the behavioral health organizations said yes. And this is very important, right? We want to have this feedback loop. Next, we're looking at emergency medical records, and we have only a few behavioral health organizations that have not yet implemented emergency medical records. We also ask, if you look at the next set of bars, are these EMRs used for clinical data? Most FQHCs said yes, most hospitals also. Are they used for decision support? Now, when you see no bars, I should have pointed this out earlier. When you see that there are no bars, this is usually indicative of 0%. So here, 0% of the behavioral health organizations are using EMRs for decision support. And the final set is EMR being used for population management and QI. And then we have the hospitals at about 80%, FQHCs at about 40%, and behavioral health organizations at maybe a little over 10%. Okay, so for this question, we wanted to understand the coordination between primary care and other types of care. The only difference, and if you look at the very first set of bars, you'll notice that there's no blue bar, no orange bar. There's no data for hospitals or FQHCs. This is because we asked hospitals and FQHCs, what type of relationship do you have what type of formal care coordination relationship exists within your organization between primary care and X? This only differed for behavioral health organizations. With the BHOs, we asked them what type of formal care coordination relationship exists between behavioral health and X. And so if you look at the very first set, we see that behavioral health organizations, maybe less than 40% of behavioral health organizations have a formal care coordination relationship between behavioral health and primary care. If we look across, and there's a lot of data going on, so please bear with me. If we look at specialty care, we see that hospitals and FQHCs have a pretty strong, all the hospitals and FQHCs have a pretty strong formal care coordination relationship between primary care and specialty care. If we look at ED, it's a little different. We would expect the hospitals have that, but with FQHCs, 20%, so maybe only one of the FQHCs, and then also it's still pretty low for behavioral health. If you look at oral health, and you'll notice this trend throughout the presentation, oral health is going to be one of those areas where things are a bit underdeveloped for a lot of providers in our area. If we skip behavioral health and look down at CBOs, we have a very limited formal care coordination relationship, which I think is also expected. Hospitals and CBOs, maybe about 70% of the hospitals have a formal care coordination relationship. But if we look at FQHCs, only 40%. If we look at behavioral health, less than 40%. Okay, so unfortunately, these data show that workforce gaps and barriers are everywhere. They are ubiquitous. There are, for hospitals and for FQHCs and behavioral health organizations, almost every provider mentioned that they have significant workforce gaps or barriers to team-based care. Here, we're looking at team composition, and it varies wildly based on the setting. I think most of this is to be expected. However, we have 90% of the hospitals reporting that they have case managers. But if you look at community health workers, less than 40% of the hospitals have community health workers. And if you look at peer support specialists, less than 20% of the hospitals have peer support specialists. However, if we look at behavioral health organizations, about 70% of these organizations have peer support specialists. For this next slide, we're looking at, for this next slide, if you look at the first set of bars, we're trying to determine what are the workforce concerns. And this should be to the surprise of no one. Funding uncertainty is very high across all settings. For anyone who's ever worked in community health or public health, funding uncertainty is kind of a floating theme. And these data show that this holds true even in hospitals and FQHCs and behavioral health organizations. Staff turnover is, I think, about maybe about 75% of the behavioral health organizations reported having an issue with staff turnover being a concern. For FQHCs, it was about 60%. Hospitals, it was a little over 50%. Quite a few hospitals, maybe about 70% of the hospitals, reported finding qualified community health workers or peer support specialists as an issue also, which is incredibly high. The positive for this is that very few organizations reported issues with management support. No hospitals, 20% of FQHCs, and a little over 20% of behavioral health organizations. And only less than 20% of the behavioral health organizations have an issue with staff acceptance of CHW, community health worker, or peer role. So not all bad. Next, we're going to discuss culturally and linguistically appropriate services. So as we can see here, use of culturally and linguistically appropriate services is high. And this is incredibly important because we really need to understand how people are receiving their information, and if people are receiving their information in a primary language or in a language that they can fully comprehend. And when we look at the first block and we're looking at the use of culturally and linguistically appropriate services in missions and in mission statements and in principles, 100% of FQHCs report this. A little over 90% of behavioral health organizations report this. A little over 80% of hospitals report this. So we're doing incredibly well in having it in our mission statement and in our principles. When we move over to use for planning, we have 100% of the hospitals, but only 60% of the FQHCs and only about 50% of the behavioral health organizations. When we move over and we're looking at policies and procedures, almost all of the organizations are using this, and that's fabulous. And then we have training next, and maybe about 90% of the hospitals, 60% of the FQHCs, and a little over maybe about 75% of behavioral health organizations have training for this. And then interpreters for the 5 top languages, which the top 5 languages, I can't remember: English, Chinese, Vietnamese, Somali/Amharic, and Tagalog, right? Interpreters for those top 5 languages. Unfortunately, the issue that we found is that materials are not consistently translated. So consent is something that's incredibly important. We're going to the hospital, and the first thing that we need to do before we receive any sort of treatment is understand our rights as a patient. So it's incredibly important. So you have about for the FQHCs, they're doing incredibly well, but with the hospitals, maybe only about 70% have the consent translated in these 5 languages. The behavioral health organizations, maybe a little over 80% have these materials translated. With medical instructions, only about 60% of the FQHCs have these translated, and then under 40% of the hospitals, and maybe about 10% of the behavioral health organizations. Discharge planning instructions are also pretty low. One bright point is that health education materials for the hospitals and the FQHCs are at about 80%, although it's only over 40% for the behavioral health organizations. All right, let's talk about value-based payment. So here we're looking at value-based payment, and we could see that. If you look at this first block, we could see that for the hospitals, 100% of the hospitals, their contracts include VBPs. And I think it's expected that the hospitals will be a little ahead of the game in this arena. With FQHCs, we have 80%, still pretty substantial. And then for behavioral health organizations, we have about 30%. If we move over to population health management, this is the next to last block. 100% of the FQHCs. I think that's just really amazing. We have about 90% for the hospitals, and then maybe a little over 20% for the behavioral health organizations. And then last, if we look at links to social determinants of health, maybe a little over 40% for the hospital have links to SDOH, maybe 60%, about 60% for the FQHCs, and then a little over 50% for the behavioral health organization. So this is an area that is lagging, and this is definitely an area where we can improve. Okay, looking at this slide, we can see that some of these value-based payment barriers cut across settings. We have so at the bottom we have care coordination, data analytics, post-acute care, care transition between screenings, and ID integrating with community-based organizations. And we can see that there are pretty similar measures for most of these. Now here, we can see that other value-based payment barriers vary by setting. If we look at health information is really high for behavioral health organizations. It's almost a little over 90%. Also pretty high for hospitals. It's a little over 80%, at about 60% for FQHCs. If we look at patient engagement, this is pretty high for hospitals. Also a little over 80% for behavioral health organizations, but maybe only about 60% for FQHCs. If we look at physician alignment is very, very high for behavioral health organizations. It's only about 60% for FQHCs and a little over 60% for hospitals. And also, I want to draw your attention to the very last block, EHRs, electronic health records. So here, it's only about 60% for FQHCs, a little over 60% for behavioral health organizations, and a little under 50% for hospitals. So this is an area where we could stand to see some improvement also. Okay, so for this question, we asked agencies, we asked providers, what do you need help with, or with what could we help? And if you just look across these different points, we have patient engagement solutions, population health management, community partnerships, support building new care models, data analytics, quality improvement, practice transformation, care coordination, centralized care management, and credentialing. We asked to check which of these items providers needed help with, and behavioral health organizations were much more likely to report needs across all of these topics. If you just look across that 80% line, you just see great. And so I think this is potentially indicative of where we may want to concentrate some of our support. Okay, next we're going to talk about bi-directional care. Okay, so for this question, we asked providers what was the most common model for their plan implementation, And we see that collaborative care was very popular. See that maybe about 90% of the hospitals are using collaborative care. And then we see that a little under 80% of the hospitals are also using pre-care or pre-collaborative. And maybe a little over 60% are using the enhanced. We also looked at training needs, and we wanted to understand here. What are the? Sorry, 1 second. Okay, so we wanted to understand here what are each organization's needs for training. And if we look at this very first block, we have quite a few hospitals that say they lack a plan for integrated care. Almost 90%, 80% of the FQHCs lack a plan for integrated care, and a little over 40% of the behavioral health organizations. And we asked if there's training needed for integrated care. Maybe a little under 60% of the hospitals they need this. About 40% need training. 40% of the FQHCs need training, and 100% of the behavioral health organizations also need training. If we move down and look at financial system barriers, we see that this is also a problem for quite a few organizations. It's an issue for maybe about 80% of the hospitals, 60% of FQHCs, and about 85% of behavioral health organizations. And we also see that contracting barriers may also be an issue for quite a few organizations. Okay, so we also looked at some of these MIHAP areas, and some of them show strength across settings. For example, social support for patients to do recommended treatment. 100% of hospitals are reported yes, or reported a score of greater than 5. And the way that these were calculated, if scores were at least 5 or more, then this indicated partial or at least full implementation of this area. So 100% of hospitals answered 5 or more. And then for FQHCs, it was about 80%. And for behavioral health organizations, it was about 80%. And these are pretty strong for these three: social support for patients to do recommended treatment, linking to community resources, and emotional behavioral assessment integration. But if we look at the following, and if we focus on the gray, we can see that quite a few behavioral health agencies lag in a lot of these areas. If we look at funding resources integrated, this is pretty low for behavioral health organizations, maybe about 15%. The same for treatment plan for primary care and behavioral health integration. Also for co-location. Okay, next we're going to discuss transitional care for a bit. So if we look at the interest in transitional care subpopulations, this data shouldn't surprise anyone. We're asking about interest in 3 subpopulations, which is for anyone on the phone who is not familiar. We have people returning from hospital, high prism returning from hospital, and for the hospital, this interest is incredibly high. It's about 90%. FQHCs indicated about 60%. or 60% of FQHCs indicated some interest, while 60% of behavioral health organizations indicated some interest. When we go to the next block, and now we're discussing interest in populations returning from jail. Now we have FQHCs, our traditional community health centers that service the medically underserved. Now the interest here is quite high, while for hospitals it's dropped quite a bit. Now it's a little above 20%. And for behavioral health organizations, it's about 90%. And then the last block, we have hospitals very interested in people returning from inpatient care. For FQHCs, it's only about 60%, and for behavioral health organizations, it's at about 90%. Okay, so looking at this next graph, what we can see that services for discharge services are a strength of hospital systems. If we look at this first block, clinical case management for high-risk complex patients, we have maybe about 75% of the hospitals, and only about 20% of the FQHCs, and about 60% of the behavioral health organizations. And one that I'd really like to point out is in the center, patient caregiver education using teach-back method. And so we have about 85% of hospitals doing this, 85%. And for the FQHCs, we don't have any using the teach-back method. And this is I teach you how to take your medication, or I talk to your caregiver about how to take your medication, and then you teach it back to me. And so outside of hospitals, this isn't going on very much. With behavioral health organizations, maybe about 30%. And then if we look over at risk stratification, for risk stratification, which is separating low risk from high risk patients, we have maybe about 85 to 90% of hospitals doing this. FQHCs only about 20%, and for behavioral health organizations only about 30%. Also, use of evidence-based models is pretty low. We asked the different organizations about their use of APIC among jail transition entities, and we had 0% for hospitals, 40% for FQHCs, and a little over 30% for behavioral health organizations. And we can see that it's pretty low across the board for Peer Bridger and for the Coleman model. Okay, next we're going to discuss barriers for transitional care. We're going to go over housing. We're going to talk about communication collaboration and discharge info sharing. We're also going to talk about timely access to mental health SUD treatment, specialty care clinics. We're going to talk about funding, which is always a huge barrier, staffing, and then finally SNF and AAFH funding models, beds, and willingness to accept patients. All right, so let's go into opioids right now. So with opioids, scope of practice differs dramatically by setting. We see that about 100% of the hospitals are treating chronic pain, as well as for FQHCs, but we don't have any for the behavioral health organizations. This shifts dramatically when we move over just one, and we're looking at who's providing SUD treatment, substance use disorder treatment. Maybe about 50% of the hospitals and 50% of the FQHCs are providing this, compared to 100% of behavioral health organizations. I think this is to be expected. And if we shift over just one, we're looking at who's providing methadone-assisted treatment. This is a little over 60% of the hospitals and about 60% of the behavioral health organizations, 100% for all of the FQHCs. Looking at this graph, well, one thing that we can figure out pretty quickly is that best practices, opioid best practices, are not used very consistently. The very first block of bars assess patients' suitability for opioid use. Only about 75% of hospitals and FQHCs are doing this, and none of the behavioral health organizations reported doing this. The next block, looking at providers, how many providers are screening for opioid misuse before prescribing opioids? And a little over 60% of hospitals, maybe about 50% of FQHCs, and 10% of behavioral health organizations. And if we shift over to provide overdose education, these numbers are also pretty low, only about 50% of hospitals and FQHCs and 40% of behavioral health organizations. But for the very last block of bars, prescribe naloxone at least sometimes. 100% of the FQHCs and 75% of the hospitals are doing this. So that's a positive. Looking at this graph, we can see that hospital systems are using prescribing guidelines more than FQHCs and behavioral health organizations. It looks like hospitals are most frequently implementing CDC opioid prescription guidelines compared to BRI and AMDG. And it looks about even between CDC and AMDG for FQHCs. Although we can see that behavioral health organizations may not be implementing any of these guidelines. Okay, for this graph, we could see what steps hospitals and FQHCs and behavioral health organizations have taken to implement some of these things. And so, excuse me. And so for the first block, monitoring opioid prescribing practices, we have about 85% or maybe a little over 85% of hospitals doing this and 100% of FQHCs doing this, although only 10% for behavioral health organizations. The very next one, build guidelines into EHR or build recommendations for dosage into EHR. For hospitals, we have about 75% doing this, but we don't have this happening for FQHCs and behavioral health organizations. And this may be in part because there's a lack of EHR systems for some of these organizations. Also, if we move all the way down to the very last one, providing patient education and communication tools. We have 75% of the hospitals and FQHCs doing this, and about 30% for the behavioral health organizations. So if we look across the board, you see a lot of blue and orange. Hospitals and FQHCs are taking a lot of these steps, a lot of these implementation steps, where with the behavioral health organizations, we may have a little work to do. Okay. So next, for this one, we have use of PMP is consistent. And if we look down at this very first block, we see most all prescribers registered with PMP. And for hospitals, this is true for about 75% of them, and also 75% of FQHCs, but maybe only 40% of the behavioral health organizations. For the very next block, a little over 60% of the hospitals have all of their providers using PMP, but only about 50% for FQHCs and 20% for behavioral health organizations. And then for PMP and EMR, only about 50% for hospitals, and maybe about 25% for FQHCs and 20% for behavioral health organizations. Okay, so now we're looking at barriers to PMP use, and I think that it is really nice to see that there is leadership buy-in across the board, across all settings. This was not reported as a barrier by any of the organizations. If we move over a little bit, it gets a little less happy. Now we have some hospitals reporting provider resistance, and we have a few behavioral health organizations reporting the same, although none for FQHCs. For the next block, if we look at quality and usefulness of PMP information, these are pretty low as well. Very few organizations reporting these as barriers. Lack of EHR interoperability, this is pretty high for FQHCs, as I think we might expect, 75%, and also about 40% of the behavioral health organizations. Lack of knowledge or training was reported as a barrier by about 75% of the hospitals and about 20% of the behavioral health organizations, although none of the FQHCs reported this. And time, additional processes taking too much time. I think this is something I've personally heard from quite a few providers. 75% of hospitals mention that this as a serious barrier, and about 25% of FQHCs and 10% of behavioral health organizations. Okay, next, we're going to talk about chronic disease for a bit. Okay, so here the question is, which chronic disease was of interest to your organization? And almost everyone is interested in diabetes. Everyone who is interested in the chronic disease project is interested in diabetes. We have some really varied interests in adult asthma and in pediatric asthma. As you can see, FQHCs are very interested in pediatric asthma. Only about 45% of the hospitals are interested in pediatric, and only a little over 20% of the behavioral health organizations are interested in pediatric. And with CVD, we see really high interest from the FQHCs, maybe about 70% of interest from the hospitals, and maybe about 90% of interest from behavioral health organizations. We also asked about registries, and here, if we look at, we want to know what type of registry is being used, or if a registry is in place. And the hospitals, for the hospitals, you have about 70% that have a registry in EMR. And I think of the 9, this was maybe 7. I think 7 of them have a registry in EMR. And then if you move over to registry and Excel access, I believe just one hospital has their registry in Excel access. Now, if we compare this to FQHC, we see only 40% have their registry in EMR, and we don't see anything for behavioral health organization. And when we move over to Excel access, it's 60% of the FQHC with their registries in Excel access, and a few of the behavioral health organizations. Also, we wanted to know you have a registry for asthma, for diabetes, or for other chronic conditions. And looks like about 65% of the hospitals have a registry for asthma, as about 60% of the FQHCs. And then for diabetes, about 80% for the hospitals and FQHCs, and about 10% for the behavioral health organizations. Okay, we also asked about the care plan content. We just wanted to know about the components of the care plans across different organizations. And I think it's very interesting how different care plans are structured. I'm sure everyone is looking at that big red arrow that points to a description of how services will be coordinated. And this is really low across all settings. And I think that this is a really important area, just incredibly vital. I mean, a huge part of whole person care is service coordination. So that's definitely leaves something to be desired. I also want to touch on the rest of this just really quickly. If we look at the very first block, expected outcome and prognosis for hospitals, it's about 65% of them have this as a component of their care plan. For FQHCs and behavioral health organizations, only about 20%. If we skip over to symptom management, about 90% of hospitals have this, only about 40% of FQHCs and about 35% of behavioral health organizations. And then if we skip over to medication management, these look about the same. And so just looking across, you see a very similar pattern with the hospitals, the FQHCs, and the behavioral health organizations, except for a description of how services will be coordinated. Okay. Okay, so for this question, we asked about team, and we just wanted to know what type of staff does each organization have on board. And it varies quite a bit. CHW is a community health worker. As you would expect, few hospitals have community health workers on staff, but when you move over to FQHCs, 80% of FQHCs report community health workers, but no behavioral health organizations. If you move over to social worker, SW, social worker, now we have over 50% of behavioral health organizations with social workers on staff. Only about 40% for FQHCs, and then for hospitals, about 90%. And if we look at pharmacists, 80% of FQHCs reported having pharmacists, but only about 65% of hospitals and a little over 20% for behavioral health organizations. And if we look at the last block of bars, under 80% or just under 80% of hospitals have a registered dietitian. And I think this is incredibly important for diabetes. Also, with FQHCs, maybe about 100% of these have registered dietitians or reported registered dietitians, and only about 10% of the behavioral health organizations have registered dietitians. Diet is a huge part of treating diabetes, and so that's incredibly important for chronic disease care. Okay, next we're going to talk a bit about use of CHWs. We're going to discuss financing, and also talk about barriers a bit. Okay, so let's see. Oh, sorry. Okay, so now we're going to discuss self-management, and we're looking at self-management, and we also want to determine how the hospitals, FQHCs, and behavioral health organizations are doing with self-management, on-site self-management, and if they're partnering with CBOs for self-management. And we can see that for self-management goals routinely in record, hospitals are pretty low, only about 20%. About 60% of the FQHCs, and maybe about 10% for the behavioral health organizations. If we move over to on-site self-management support, this is about 90% of the hospitals report having some self-management support on site, about 60% of the FQHCs, and a little over 20% of the behavioral health organizations. If if we shift over and we're looking at who's partnering with community-based organizations for self-management, now we have a little less than 80% of the hospitals and about 60% of the FQHCs and no behavioral health organizations. And if we shift over and look at who's using the Stanford chronic disease model, only a little over 20% of the hospitals and about 10% of the behavioral health organizations. And finally, looking at the last block, is there a diabetes prevention program in place? And this is true for about a little over 50% of the hospitals, 40% of the FQHCs, and about a little over 30% of the behavioral health organizations. And that is it.
Okay, thank you so much, Jay. We are just switching over the presenter back to Healthier Here, but in the meantime, if you have any questions about the current state assessment data, please type them into your questions pane.
I don't know if anybody would have heard you.
Okay, so if there's any outstanding questions, please go ahead and type them into the questions pane, or you can email us. Okay, so I'm not seeing any questions right now, so we are going to wrap things up. Okay, some next steps after today's webinar. If you're not already an implementing partner, please start discussing your organization's readiness and get in touch with us with that first step of completing the Financial Executor Survey. And then also keep an eye on your email for the announcement of Healthier Here's new website. That should be sometime next week. And that website is going to be a great venue to share updates and keep folks connected to our work. And then also, please stay engaged and attend the next Partner Summit webinar, which is going to be on June 21st from 2:30 to 4 p.m. That should be 4 p.m. And at the Summit webinar in June, we're going to be focusing on the results of the HIE-HIT assessment. So it might be a good idea to share out that invite to your CTO and other IT and data folks. Okay, have any other questions come in? It doesn't look like it, so thank you so much for your time today. Here is our contact information if you have any follow-up questions. We've got Twee's contact information for any finance questions, and Michael's contact information for anything related to programs and projects. So thank you so much for your time today. I'm glad we can wrap things up a little bit early. And thank you again, Jay, for presenting and sharing the results of the current state assessment. That was a true, region-wide effort. So thank you for everyone who filled that out on behalf of your organizations. So we will talk to you next time. Thank you.